Hello everyone. Today I will be mainly talking about various types of tentorial meningiomas. As you can see from these anatomic diagrams, the tentorium is basically continuous with the cavernous sinus, as you can see here, and also over here on this lateral view of a skull, you can see that the tentorium continues anteriorly and kind of blends in with the lateral wall of the cavernous sinus. And if we look here on this view from above, we can see that the two anterior ligaments arising from the free edge of the tentorium, one attaches to the anterior clinoid and the other one to the posterior clinoid. So because of this continuous dural covering of the cavernous sinus with the tentorium, it's rare to see just a purely cavernous sinus meningioma by the time we get to look at them on MR. So for instance, here's mainly cavernous sinus meningioma. We already see there's some extension towards the orbital apex, and we can also see on the coronal view the normal Meckel's cave on the left, and the right one already has tumor within it. In this other case, we see a meningioma of the cavernous sinus, again extending into the orbital apex, and also involves the foramen rotundum, as we can see on the coronal image, as well as invasion towards the V3 or the foramen ovale. And here we can see it on the axial plane, the foramen ovale involved with tumor. Also, last week when I talked about sphenoid ridge meningiomas, we again can see on one of these cases how the dural involvement of this unplaqued meningioma extends all the way back to involve the wall of the cavernous sinus. So now let's move posteriorly. Already we can see here on this meningioma of the cavernous sinus some extension posteriorly into the prepontine region, likely involving the trigeminal nerve here. We can see both on the T2 and on the post-contrast. So that's why it's not unusual for us many times when we initially look at meningiomas that we'll have extensive involvement of the cavernous sinus, Meckel's cave, and here we can see how it's extending along the free edge of the tentorium. Also on the sagittal plane, we can see the free edge involved. So it's very easy then for the tumor to extend posteriorly along the tentorium. And here's another more extensive involvement. We can see the carotid artery being encased, displaced medially. Again, a large cavernous meningioma extending posteriorly along the tentorium, as we can see again on the sagittal plane. And just to show you this route of invasion, here we have an anterior clinoid meningioma, the enhancement of the free edge of the tentorium, and look, there's now also second meningioma posteriorly indenting the brainstem. So these are two separate meningiomas, although we can see the thickened, enhancing free edge of the tentorium, most likely the route how either of these develop along the tentorium / cavernous sinus wall. And here's a case that Pradeep gave me last Thursday, or alerted me to this case. The patient had no symptoms, was incidentally found on a CT, on an outside examination, and note the marked involvement of the cavernous sinus extending anteriorly all the way back, encasing the trigeminal nerve, invading the internal auditory canal, and along the clivus here, and also invading the other side as well as the foramen ovale and the V3. So this is not unusual. Now here's an interesting case. I had to read. Patient had a renal cell carcinoma, liver and lung mets. Are we dealing with another met, or is it the meningioma? Any opinions from the audience? Meningioma or metastatic lesion? Correct. As Anshu said, and Gino, likely meningioma. There's a little tail. I use mainly my favorite sign here of the encasement and medial displacement of the carotid artery by this tumor, because meningioma usually arise and involve the outer wall of the cavernous sinus. So I said that this most likely meningioma and not a met, and it was unchanged in a 3-year follow-up. So remember that patients frequently have meningiomas and another condition. Okay, let's start with Clival meningioma, also known as Petroclivaltentorial meningioma in the neurosurgical literature. The reason they use the term Petroclivaltentorial is because a lot of people feel that these tumors arise from the petrous apex or from the tentorium itself, and secondarily involve the clivus. So here we have a small lesion at the upper end of the clivus. So here's the clivus on the anatomic, partly sphenoid, partly occipital bone, and we can see a clival meningioma displacing the basilar artery posteriorly. What are these two calcifications? Which one of them is more involved with the tumor? What anatomic structure is that? Correct. As Gino said, the dorsum celli. Okay, remember, this is the dorsum celli here, and this meningioma is sitting on top of the dorsum celli, also growing anteriorly over the pituitary fossa. Remember when I showed the tuberculum celli, they grew posteriorly over. And again, there may be some pneumosinus dilatans here. Some neurosurgeon will classify these as tuberculum cell meningioma, not upper clival meningioma. Just a matter of nomenclature. And here's a different type of an upper clival meningioma, closer to the petrous apex here, maybe arose from the petrous apex. We see on the diffusion dark, which meningiomas will do. And patient has diplopia. What nerve am I pointing to with the green arrow? Correct. As Matt says, Gino said, the sixth nerve, we can see the normal 6. We do not see the right 6, explain the patient's diplopia. And again, on this anatomic specimen, we can see the 2-6 nerve. We can see how they would be involved with this tumor. Here's a larger upper clival meningioma, this time invading Meckel's cave here. So again, the patient had double vision and 6th nerve palsy, and again we can see why. Here's the 6th nerve right next to the trigeminal, which is involved here, and we can see why the 6th nerve was involved with this upper clival meningioma. And here's a larger one. They get progressively larger. A large upper clival meningioma. Notice the encased carotid artery. Again, notice how the free edge of the tentorial is thickened and enhancing because of the tumor spread. Okay, why am I showing this, and what is the abnormality here? MRAs. Very good, as Gino said, Anshu said. But what is it besides being displaced posteriorly? It's arced. Look at the CTA, kind of a classic arcing of the vertebral system. And what's the cause of it? A very large tumor arising from the clivus. I want to point out, in the old days, prior to CT, when we used to do angiograms, you can see again, this was a classic sign of a tumor in front of the basilar that is arising from the clivus or in the prepontine cistern. A very classic sign, similar as what we see here on the MRA and the CTA. Large lesion arising from the clivus. And you can see here on this beautiful anatomic illustration, here's a retroclival lesion stretching the PCOMs, displacing the basilar artery back. And we can see on our case here, again, the encased carotid, and here's the basilar artery pushed laterally and way posteriorly. And here's a tumor on coronal plane. And again, notice how the tongue of the tumor is displacing, abutting on the chiasm, and also entered the internal auditory canal. How can we confirm that this is definitely a meningioma? We get to my favorite blood vessels, which we can see here. And remember, I've pointed these out repeatedly with olfactory groove meningioma. I've pointed them out with convexity meningiomas, and also involvement, another involvement. And here's what we have. These are these perforating branches coming off the internal carotid artery. Here they are. And these are not the same patient, but these are angiograms I did previously many years ago, again showing these vessels. And what are these? What are these arteries called? Anybody? These are the meningohypophyseal branches, the first branches of the internal carotid artery, and classic, and I'll show them again later, classic for a meningioma being supplied from the carotid artery. What do we see here? What is this dark lesion? Correct. As Gino said, again, a classic clivus meningioma. Look at the enhancement, but very dark on the diffusion as well as on the sagittal flare. And notice the enhancement, highly calcified clival meningioma. Still has some blood supply from the perforating arteries from the basilar. What is this lesion? Somebody mentioned intraosseous meningioma, but this was not the case. This was one of my cases I like to throw in. Simulates a meningioma, but was not. Here's a post-contrast. Any other possibilities? Correct. As Gino said, this was an undifferentiated carcinoma, metastatic lesion. What are we dealing with here? Another non-meningioma type lesion. Correct. Gino already has the diagnosis. Anybody else wants to volunteer a diagnosis? It's no longer a met. As Gino said, this is a chordoma. And again, notice chordomas tend to be quite bright on the T2 imaging. And here's another lesion, unusual looking, arising from the clivus. This was another chordoma. And while we're on the subject of chordoma, I don't know if many people remember, but this is a lesion I showed when I was discussing the hypoglossal canal. Notice the marked destruction of the inferior clivus here, and there was involvement of the hypoglossal canal. Again, the entire occipital portion of the clivus was removed, is destroyed. And this was, again, here's the MR showing the lesion arising from the clivus, indenting, deforming the medulla, very bright on T2. And this was a large, massive chordoma, again, involving the inferior clivus. Okay, what is this unusual case with a very peculiar name? Very good. Anshu came up with this very hard name to remember. This is Acordosis phyllocyfera, which is actually what it is a remnant of notochord. Some people feel that it's really that chordomas and this lesion are just a spectrum, that the chordoma just is this lesion, which is a hematomous lesion, a remnant of notochord tissue. Usually these are asymptomatic. This one happens to be within the clivus, but sometimes they'll actually be outside as a retroclival lesion, but usually they're asymptomatic. And I just wanted to show this lower clival meningioma, kind of now in the region of the foramen magnum, and again, from the old days, this classic backward bowing of the vertebrobasilar system, again, not the Hopper one like on the prior case I showed. This one looks normal, but this is lower. It's not the same patient, but this also was an indication that we were dealing with a pre-brainstem or medulla lesion causing this classic angiographic deformity. And I'm not going to show a whole example of foramen magnum angioma. I just wanted to show this large one has a little bit of a dural tail, so it still qualifies a low Clival lesion / foramen magnum. You can see the marked compression of the medulla by this large meningioma. Okay, now let's talk about incisural meningiomas. These are meningiomas which arise from the free edge of the tentorium. The incisura is this area of the tentorium that actually, as I mentioned earlier, attaches anteriorly to the anterior and posterior clinoids. And here's an incidental incisural meningioma. We can see it over here. And if we look at this, again, I showed you here, it's hard to tell. But if you look at the coronal MR here, so here on this anatomic specimen, here's the tentorium. So that would be someplace over here, kind of attached to the incisura of the tentorium. And on the sagittal view, you can see it over here. It's hard to tell exactly where it is here, but again, you see here's the tentorium and then the sagittal cut. So it would be in this location. These can get larger, and here's another incisural meningioma, and we can see how the incisura of the tentorium is thickened on this side. Again, tumor spread, the so-called dural tail involving the free edge of the tentorium. I want to point out on this CT a very important sign that I like to use, and that is the widening. Notice the widening of the CSF space there. And this is a classic sign for an extraaxial lesion pushing the brain, or this, and this especially was useful in this when we used to do myelograms for spinal tumors, that it was always an extraaxial lesion by displacing the cord, or here the pons, that you get widening of the subarachnoid space on the side of the lesion. So this was really a classic sign, and it even holds here where we see the widening compared to this sign. This will only happen with an extraaxial lesion or a large exophytic lesion arising from within the brain or the spinal cord, but that's very unusual. This sign is very useful for making diagnosis of an extraaxial lesion, like this meningioma. And how do these look? So here we have a surgical diagram showing the free edge of the tentorium, and here is this lesion. What these lesions tend to do is to grow around the temple bone, on the upper surface of the temple bone and on the medial surface, and something even further. So here's, for instance, one of these meningiomas. Here it looks like two separate meningiomas, but as you go up high, you can see it's a single. And here on the coronal plane, see the temple bone, and here's the meningioma kind of straddling the apex of the temple bone, as it can be seen on this surgical diagram. So this sits along here on the upper surface and then going inferiorly to cover the temple bone apex. Here's a large one that Rick gave me. Again, notice a huge meningioma sitting over the temple bone. This one extending posteriorly. So this is actually, if we look here, it's really this part behind the bone, as we can see. So it's not the CP angle lesion per se. It's really started higher and then grew down into the Cerebellopontine angle. Okay, now let's move to another group that involve the transverse sinus, the sigmoid sinus, and the torcular. So these are grouped as separate because of the involvement, possible involvement of the sinuses. So here's a lesion, again, at the transverse sinus, and again, CT shows the calcification. No question, we're dealing with a small meningioma. Again, an incidental finding sitting over here. So again, here's the tentorium. Here it is on the anatomic specimen, sitting close to the sinus, transverse sinus here. Here's a larger one. Again, here's the sinus on an anatomic specimen. So this is slightly off, did not occlude the sinus, but has to be watched. And here's, of course, a larger one of this transverse sinus, and this one shows on a MRV that there's occlusion of the transverse sinus on the axial and also on the coronal images. Here's a nasty looking lesion, meningioma, and this was an atypical grade 2 meningioma with potential malignancy. And again, notice the very irregular appearance, the inhomogeneous enhancement, and again involving the transverse sinus. Here's a very interesting case that Gino and I discussed over this few days ago, on last Saturday. This patient was on Lovenox and also had a history of breast cancer, and came in, had a CT scan which showed a hemorrhage and also showed a tiny calcification. So the question was, is this a metastatic lesion? Was it just a bleed because of the patient was anticoagulated, or was it bleeding meningioma? Remember, bleeding meningiomas, which I've said before, are extremely rare, and it's hard to find really a bona fide case where nothing happened or the patient was not on anticoagulant to show really that the meningioma bled. So, and then Gino did an MR, and again we see that this calcified meningioma is enhancing markedly, and here's the hematoma we can see in the SWI. So we have a little meningioma and we have a large bleed. So this meningioma bleed, this was operated on, and it was a grade 1 meningioma and the blood products that we can see here. I would say that this is just a coincidence. First of all, grade 1 meningiomas never bleed really. So I think that because the patient was on anticoagulation, whatever reason, we have an association of this meningioma with a hematoma that was adjacent to it, and that the meningioma is really not the cause of the bleed, but people may disagree. Okay, what about this meningioma that I myself read as a classic meningioma involving the tentorium? Anybody want to agree or maybe bring up another diagnosis? Well, I was surprised. This was a cavernoma at surgery, not a meningioma. Sure looks like a classic meningioma. What about this meningioma? Again, looks like a meningioma. How about these images? Edema, maybe a little calcium in the center. That was a MET from a breast carcinoma, simulating a meningioma. Another lesion, looks like a tentorial meningioma. This was a metastatic lesion from lung. So remember the many simulators for meningiomas. Now sometimes these meningiomas, which are laterally involving the sinuses, can get massive. Here's another case that Rick gave me, and notice it's eroded the tentorium here. I'm sure affected the sinus, occluded it, and here we can see this type of a lesion on either side of the tentorium. Here's the infratentorial component, above is the supratentorial, and you can see how large this is on the coronal. So again, kind of encasing the lateral aspect of the tentorium, eroding it. And now we'll move towards the region of the torcular. Torcular meningiomas are quite rare, and this was my attempt to find one. This was incidentally just adjacent to the torcular, but not really a true torcular lesion. Here's another one actually close to the torcular, but arising from the straight sinus. Did not really cause anything. Again, an incidental finding. But this is a bona fide torcular meningioma, as you can see at the junction, and also involving the inferior part of the straight sinus. So this is in the torcular meningioma, and would eventually get large enough, would have a major effect on the veins here. Okay, let's talk now about what we call the Cerebellopontine angle meningioma. Also, the neurosurgeons refer to this as the posterior petrous meningiomas. I'm not going to spend a lot of time on this, as this is a board review topic. I just want to point out this tiny meningioma here. And we know it's a meningioma because, notice, it's in front of the IAC. Here's the 8th nerve, the 7th nerve are coursing behind that. So it just happens to be a tiny enhancing meningioma. And again, this is a meningioma which we know can invade the internal auditory canal. What about this Cerebellopontine angle lesion? Does not look the typical meningioma. And this was a grade 2 atypical meningioma. It's kind of unusual way of enhancing. May have been necrotic in the center, but this is a potential malignancy. Unusual appearance, however. And you can see this is one patient with, you would call it, here's a temple bone, a posterior temple meningioma. These are two other cases. As you can see, these lesions can get progressively, or those are two separate patients, but you can see they can get quite large. This patient had a lung CA, had a MR to look for Mets. This was read as a metastatic lesion from the lung meningioma. 10 months later, there was a CT follow-up. I don't think that this was a Met to start off with. Again, I cannot stress enough to make use of CT, prior CT, or anything, just to confirm. Remember, 70% of meningiomas calcify. So this was unnecessarily called a metastatic lesion when it was just, and again here you can see that it was already centrally suggesting calcification. So this was a posterior temporal meningioma, not a metastatic lesion. Okay, now let's move on to what's called the Falcotentorial pineal region meningiomas. Now, the reason they're called Falcotentorial because this is the junction. So here are the two leaves of the tentorium coming up to meet the falx. And that's why they're called Falcotentorial. Also, so here it is. Here's the falx. We cannot see the tent on this view. So this is the area. Also, if you look here, at this whole region, this is where the pineal sits, right behind the back of the third ventricle. So here we have this lesion. So this would be pineal region lesion also at the falcotentorial junction. So what is that? Again, CT to the rescue. So this is again a small meningioma kind of sitting, displacing the internal cerebral vein in the back of the third. Could it be a pineal region tumor? Maybe, but not likely. Much more likely to be a small meningioma. Here's a larger lesion. Here it is. Falcotentorial. Notice how it's deforming the third ventricle. Again, CT to the rescue here, or at least confirming the diagnosis, another pineal region meningioma. I just want to point out this very important sign of this kind of like a thumb pushing into the back of the third ventricle, which we see here full of CSF. Notice this is the normal. So here's the pineal. Here's a quadrigeminal plate, and we see the suprapineal recess and the aqueduct here. This is all kind of pushed forward, and this is rounded appearance by an extra ventricular mass. An intraventricular mass will never do that. Anytime you see this curvature, that has to do with an extraventricular mass. In this case, again, a larger calcified meningioma. Here's another one on MR. A lesion here deforming the splenium. Again, at the junction, well, it's actually a little higher, but this is where the falx would be. So again, a falcotentorial lesion. And again, notice on the CT, the rim of calcium here. Again, a falcotentorial / pineal region meningioma. And you could actually see the pineal here, so this has nothing to do with the pineal. They can get large. Here's a large one, again with the classic deformity of the third ventricle. Here's an anatomic diagram what these lesions would look like. And these are very old pathology specimen prior to diagnostic tools like CT and MR, showing these massive tumors of the tentorium / falcotentorial meningiomas. And here's another case that we had showing this massive falcine meningioma. Also notice it's kind of involving here. So this again a falcotentorial meningioma, maybe mainly falx, markedly deforming the adjacent brain structures. And again, this is an old angiogram. Remember I talked about the dual supply when I was talking about convexity meningiomas, where the initial supply is from the external, then and then the internal carotid takes over to supply the periphery of the enlarging tumor. Here again, this is the internal carotid injection, and these are the meningohypophyseal branch. This is the meningohypophyseal artery, which gives off these tentorial. This was a large tentorial meningioma. So this is the stain being supplied by the meningohypophyseal artery. So this is the stain of the tumor. And then if on the injection of the vertebral artery, we see the posterior cerebral circulation and a different segment, the more peripheral segment of the tumor is supplied by posterior cerebral artery branches. So all these voids may be being supplied by the meningohypophyseal or the tentorial artery. This is not the same patient, but just to show you that a lesion involving the tentorium, where again would look like this if it got large enough. If you had an angiogram, unfortunately, I do not have an MR of a lesion like this because I would like to again demonstrate how MR can show you these branches. This is actually like almost like a middle meningeal branch, except this way it comes off the carotid. And this nice diagram, these authors looked at several hundred anatomic specimens to classify the variation. And here's a meningohypophyseal trunk. The tentorial artery, which is this artery we see here, comes off the meningohypophyseal trunk. Sometimes it will come off directly the carotid artery. The first people to describe this arteries were two Italian authors, Bernasconi and Casanari. And for years, we all had to remember this very musical name, Bernasconi and Casanari, still being used, who first described this tentorial artery on angiograms. But we can see, well, I'm sure we will see it on an MR also. Okay, what am I showing here? A little enhancing lesion. Where is it sitting? A meningioma, but where is it? The question is. Correct. As Gino said, a meningioma at the foramen luscula. And of course, here's a CT showing a large calcified lesion. And if we look now, if we look at this anatomic specimen, this is the lateral aperture of the fourth ventricle, also known as the foramen lusca. So here, there's a large tuft of choroid. You can see here. So, and here it is on the specimen, and this is, and here it is on an MR with more normal marked enhancement. So this is the lateral foramen over here. So this meningioma is in the lateral aperture of the fourth ventricle, right in this location here. This is not the same patient. These are normals. Forgot to put normal on these images. So this is, Gino said, meningioma of the foramen of Lusca, calcified. Another enhancing lesion. Where is this meningioma? Correct. As Gino said, this is in the choroidal fissure. Now, if we look at this anatomic specimen, again, coronal view, lateral ventricle was choroid. Remember, the choroid goes from the lateral ventricle to the temporal horn. There's no choroid and no occipital horn or the frontal horns. And here's the hippocampus, and above the hippocampus there's a choroidal fissure with choroid plexus, and here on the normal we can see the enhancement of the choroid. And here's an pathologic specimen showing again this choroidal fissure meningioma. Again, you can see how the hippocampus is deformed here with this lesion. So that's what we have here, a small choroidal fissure meningioma, incidentally found on an MR study. The last group I want to talk about, which are very, very rare, intraventricular meningiomas. Again, the differential here is choroid plexus tumor. We won't get into that, but this was a meningioma involving within the ventricle. Here it is again, and so this is the last group of meningiomas that I wanted to discuss. Now, as we have a little time, I wanted to go into this case, the issue again of bleeding meningiomas. Again, this is a case that in January I went over with Eric, who brought this to my attention, and then again Gino and I talked about it this weekend because of the follow-up. So this patient in 2000 had this tiny meningioma overlying the left convexity. Some of this history and some of the images showed up later. Then this was an image that Eric mentioned to me, and because of this, could this be a bleed within the meningioma that has gotten larger? Because the next study that we had was really in January. But in intervening, there was an outside study in 2004. The patient had a car, I think, it had some sort of trauma, had this massive subdural. So this was surgical results for evacuating the hematoma, because the surgery was posterior to this lesion. So patient then had CTA, which I think Eric read, and it really, although the enhancement was not like a meningioma, there was still, because of the location here, could this have been a bleeding meningioma? But again, the history is always muddled in these bleeds of meningiomas because of this bleed, which was in the intervening years. Patient then in January, in January also the patient had an angiogram which did not show a typical stain of a meningioma. So again, the question was this a meningioma that bled, which again would be extremely unusual. Patient then had an MR, and the reason why the patient came in January, patient had an accident, had seizures following the accident, and was admitted because of seizures. And again, to complicate things, also had a history of breast cancer. So meningioma, breast cancer, trauma, prior bleed, interesting mix. But here's the MR showing the loss of hemosiderin, also marked enhancement. And this patient was operated on, and again was a meningioma grade 1, which never bleed, scar tissue, and blood product. So again, we're left with this dilemma. Was this a bleeding meningioma, or just the meningioma was associated with some prior residual bleed because it was just blood products of various ages here. So just to point out that these cases of bleeding meningiomas always have some confounding factors to it. But there was no metastatic tissue. It was strictly meningioma, scar, and blood product. And this is the last image I want to show on the series of talks on meningiomas. Please remember that CT, the calcification, is extremely helpful sometimes in diagnosing these lesions. And many times a patient would have had a CT, had an abdominal CT, or other type of, this will show the calcification. Or if not, you can order a CT to confirm the diagnosis on these cases. Thank you for your attention.